can I invite all the speakers to be on the stage for the discussion session?
I'd like to congratulate Afifi on the excellent talk on POCUS. I think, as also a POCUS practitioner, I feel that those of you who are doing RA, it's not difficult migration from just RA and lines, but also to do more ultrasound applications perioperatively. And I think, probably KKM, the universities should think of actually adopting this, because Afifi and I have been talking about this for more than 10 years now. So I think now we see, at least we could see the emergency and intensive care literature is full of POCUS. But I think the anesthesia literature is a bit slow. Even in the RAPM editorial and all the series came only in 2017. But I think in Malaysia it's slower than that. But I think hopefully you guys who are doing RA, we need to embrace POCUS now. Those are my thoughts.
On that note, I would also like to invite all the practitioners, experts, specialists to join the ultrasound SIG and the College of Anesthesia. I think it was just organized last year, so we are looking for more people to support the group. We would want to have a proper credentialing pathway among anesthesiologists. I think a lot of you would also know by this time our intensivist colleague has already had their own kind of concerted effort to have a kind of a framework of training. They have what we call acoustic program, but they are also stumbling on difficulties to get it properly done, and they actually would like to have a collaboration with the ultrasound SIG and the College of Anesthesiologists. I think those are the things that could be looked into in the future, especially under, I think Dr. Amir and the regional sub can take the lead on this as part of the project.
Okay.
Question?
You want to ask a question?
No, I'll ask a question.
Okay, sure.
So, but if this is more of private practice, so if you use ultrasound on patients for POCUS, the insurance is going to query why you charge ultrasound 200 ringgit. Then would they ask, would they query why Dr. Khoo used ultrasound on patient? That's because he's not faster.
Let's cost analysis question.
I think the only thing that's, I'm sorry for those who are in government, I think the only thing that I charge is echo, because they say there are 2 grades of echo. So because I do the focus echo, so that's a lower grade. Then there are things like, if I do, now since I've got an interventional radiologist, I don't do things like that. Sometimes previously they refer me to do an ultrasound guided thoracocentesis, drainage and things like that. There is actually various, you have to look up, I think under respiratory there's also thoracocentesis or pleural drainage of some sort. So those are the things. But the most other assessments, of course, if you do fast and you do things like, they are probably not so chargeable. I guess occasionally, things like sometimes surgeons ask me, can you help me? For example, airway, I've had the ENT surgeons when you have very obese patients. Okay, sometimes when they're waiting for, when they're doing a foreign body and they're waiting for the II because they are the II is next door, so I just put the ultrasound on. That's where you do the incision. So that of course that is not chargeable because there's no code for that.
You just want to add a bit more. Reading through literature, the reason why Davinder Singh developed the curriculum with his group in the Duke University and they introduced foresight was mainly to get insurance company to reimburse their POCUS. So the way they do it is by reporting it using the IAIM framework. You can read the article on IAIM, I think it's free access in the ultrasound journal. how billing can be done with the IIM. So the insurance company in the US is taking US as the lead. Malaysia can follow suit, probably in private. So they have a complete report. This is done by radiologists and POCUS report. So they accept a POCUS or FOCUS report as part of the framework that could make the reporting claim on insurance. IIM, indication, acquisition, interpretation, and management. Very small, simple report that can be done.
Any questions from the floor? Yes.
Hello. Good afternoon. Assalamualaikum. I'm Hidayah. Actually, I would like to ask a bit about patient satisfaction. As we know, in KKM hospitals, there's a very big learning curve that we need to teach our MO and then sometimes our friends or junior specialists. So I wonder sometimes when we teach, besides the patient doing regional, which is not under sedations, how do we approach patients that telling patients that we are teaching our junior to increase their satisfaction?
Okay, this is just based on my experience. I guess one of the important, if you read through the literature, one of the important factors for satisfaction is the perception of competence. So meaning, so I presume if you're teaching a trainee, sometimes the patient may perceive that the actual operators may not be competent yet. Okay, yeah. So, but I think there's also this role of communication, as I thought. So if the patients do understand that, particularly in public hospital, there's the burden of training. So one of the things that I showed the review article is the training bit. So the success of regional anesthesia review article in Anaesthesia 2021 is also the importance of how do we get the next generation to do this. So I guess it's also boils down to important, but based on my private practice experience, it's good to sedate them so that they don't listen too much. It depends on what kind of sedation you're aiming for, but if they don't listen too much, or if they listen but they can't recall, that's a good thing as well. My thoughts.
Yeah.
One last comment. Right. So then for RA, for regional anesthesia, if we can prove that regional anesthesia can prevent chronic pain, there's going to be a big save cost for the whole. Right? If anybody can design a study, can do that and prove that, then a big win for RA. RA will be the big win. Right? That's my final point. Although it doesn't sound very important enough, but just think of the chronic pain, how it impacts the whole economy, the medication it uses. If we can prove that it reduces chronic pain, then RA will be the win. Right? Okay.
Any more questions from the floor? Okay, I just want to add a bit. I know Dr. Mahfiz is not around, but from talking from the view of point of view of from government hospital, I think about cost. Outcome. I like that equation: value equals outcome over cost. In government hospital where the costs are heavily subsidized, I know a lot of you don't think when you open the syringes, the needles, use the most expensive needles. Okay, and I'm not against that, but that in private hospital all are chargeable, and we can see when we avoid general anesthesia and we do regional anesthesia, we can actually see, we save on the volatile agents use, we don't use the induction agent or something like that. But in government hospital, we don't see that because we don't really charge the patient individual. So, but I really hope you become, after this talk, you become a bit of cost conscious Okay, and of course we want a good outcome. We want patient go out of OT with high satisfaction, but at the optimal cost. Okay, so rasa macam very cost conscious pula. So but I really sometimes I'm a bit not to say angry, especially when you drop a needle, an 80 ringgit needle on the floor, macam, oh, okay, that kind of thing.
There will be a change in the health financing system. You are probably privy to any discussion out there with the new government.
Not at the moment. Tunggu pilihan raya akan datang. Okay, I think let's thank all the speakers in the usual manner.